Okay, ma'am, you can start now.
Very good evening to all. I am Dr. Mukundraj Keni, medical advisor for Janssen Pharmaceutical Companies of Johnson & Johnson. I welcome you for today's webinar, that is Migraine Expert Speak. This is the second webinar for the year 2021. For today's webinar, we have a very unique topic, that is cost-effective approach to migraine in a resource-poor setting. Probably this is the first time this kind of topic is being discussed in relation to migraine in India. So for this, we have a very eminent speaker among us, Dr. UK Mishra. It is my privilege to introduce Dr. UK Mishra. He is the ex-professor and HOD Department of Neurology at SGPGI Lucknow. He is currently the Director of Neurosciences at Apollo Medics Specialty Hospitals in Lucknow. He has completed his MD in Medicine and DM in Neurology from KGMC Lucknow. He has an experience of more than 35 years in the field of neurology. He has, to his credit, more than 400 research publications, and he has also been a principal investigator for more than 10 clinical trials. He also is the author of 4 books in the field of neurology. His special interest area include CNS infections, clinical neurophysiology, and migraine. With this introduction, now I would like to hand over the session to Dr. UK Mishra. Over to you, sir. Sir, you are on mute. Sir? Yeah.
Can you hear me now?
Yes.
Am I audible?
Yes.
Okay. So I thank the organizers for giving me this opportunity to present this subject on migraine, cost-effective approach. I will tell you in due course why this subject is so important and what we can do about it. You see, migraine is a common condition. It's a genetic disorder with epigenetic influences. And it is commoner in females. 18% of females and 8% of males suffer from it. And the lifetime prevalence of migraine is about 25% in females and 8% in males. Migraine, you realize that is often underdiagnosed and often untreated. You know, like many other disorders, there is a treatment gap. There is a it's very important because it's such a common condition and it's got significant. It's a very common cause of medical leave, absence from work, has economic consequences. So and even in resource poor countries, it's also a very important condition, though it's much overshadowed by other disorders like nutrition, infection, and so on. This slide shows to you the global prevalence of migraine and the number of studies which have been done. Suffices to say that every country has migraine. People in every country have migraine, and the studies have been variably different. In developed countries, there are more studies. Developing countries, there are fewer studies, which is obvious. But we must realize that migraine is a common condition. And how common is it? This slide shows to you the common medical disorders like depression, hearing loss, deficiency disorder, COPD, and so on. And then I have, and their frequency has been mentioned in this slide. And you can see that migraine is here. So migraine is much though incidence wise it's a little less common, but then again it assumes a great significance. Then this is an interesting study, a telephonic survey of migraine patients was done, published by Lipton et al. And what was the reaction of patients about migraine? 30% in USA never consulted a doctor. And why not? But the headache was not that bad in 50% patients. They said that it was not a very significant condition for them. And then 40% felt that doctors don't have useful treatment for it because they were not responding very well. Then seeing a doctor was too expensive in one third, even in US, doctors are expensive. And 50% felt doctors can't help. Obviously, they were not responding well. And 70% were not very satisfied. And interestingly, what would the patient want? Many patients wanted relief, but a number of patients also wanted to know about the mechanism and basis of migraine. This is to give you an idea about the patient's perspective about migraine. Now, when I talk of cost effective management, it is not that want to do is that manage headache with the lowest cost without compromising the quality. It is not the question of using the cheapest medicine, but what we want to do is that diagnose it early, diagnose it properly, treat it well, so that unnecessary wastage is not resources are not wasted, and those savings can be utilized for better or optimal utilization of the patients. Now, what are the barriers when we want to approach a cost-effective management? What are the problems which can lead to the efficiency of cost-effective efficiency goes down and we become unnecessarily expensive? What is the correct diagnosis? Second is the inappropriate drug choice. Supposing we have taken a wrong choice, which is not likely to respond or will have undue side effects, of course, it will be not cost effective. Then if we don't attend to the comorbidities, again, it will be a barrier to cost effective management. Then non-targeted investigations. If we do unnecessary investigations, then of course, the management will become very expensive. Then, one more important thing is that search for rare secondary causes. As you will know that primary headache are commoner than secondary, and then there are rare causes of secondary and common secondary causes. So if we try to search out every secondary cause, then the treatment will become very expensive. And excluding most unlikely causes, some young people or very bright people who are academically, they have a lot of knowledge, or they want to exclude every possible cause, and then it becomes very it becomes very expensive. As I said, that primary headache is more common than secondary headache, and migraine is diagnosed by history and examination and not by investigations. These are the myths about migraine that which is very prevalent, that brain tumor is the commonest cause of headache, which is not true, because headache can be because of various other causes, and tumor is a very rare cause, which I will again discuss later on. Blood test cannot diagnose migraine. No blood investigation will diagnose migraine. In majority of patients, no investigation is needed, but in some cases, of course, rational investigations are required, which I will discuss. And when you do a lot of investigations, there is a chance of coincidental pathologies, and which may be up to the tune of 1 to 2%, and which may be the cause of anxiety, and therefore they should be avoided, which I will again discuss. So coming to the diagnosis of migraine, there is a whole lot of International Headache Society criteria, which are very difficult to read and remember. But then, to simplify, I have given one slide that common migraine, you have to have 5 attacks of lasting for 4 to 72 hours. In children, the attacks may be shorter, but generally we need to have 4 to 72 hours of duration of headache. It is generally unilateral, it is a pulsating character, moderate to severe pain, and is aggravated by activity, coughing, sneezing, climbing, thumping the foot on the ground. These things lead to aggravation of headache. Then there may be nausea, vomiting, photophobia, phonophobia, and other symptoms which are important. So if we give attention to these things, then we will be able to diagnose migraine with reasonable surety. Now, Migraine with aura, it is migraine with aura is less common in Asian countries. It's more common in Caucasian people, and you should have one or more recorded auras, which may be visual, sensory, speech, language, motor, retinal, or brainstem symptoms, which should last for 5 to 60 minutes. And at least there should be one aura symptom which should be unilateral, and it should be accompanied or followed by headache within 60 minutes. So if we adhere to these criteria, the diagnosis of migraine will be reasonably sure. Then we always, when we diagnose, all the definitions always say these are the characters of migraine, but a secondary cause should be excluded. So we should always keep in mind that when we are diagnosing migraine, there may be secondary causes. So what are those points which give you an idea about a secondary cause? Number one, age above 50 years. Usually migraine is a disease of younger people, children, adults, young people. But if a patient has headache starting at 50 years, it is unlikely to be migraine or a rare type of migraine. Then rapid onset. If there is a very rapid onset of few months, headache is appearing, you don't consider migraine. Other possibilities have to be considered. Then comorbidities like infection, cancer, or some other disorder which a patient is having, well, migraine may be less likely, or at least secondary causes should be excluded before diagnosing migraine. Then aggravation by position or Valsalva. Supposing patient has, on straining, he has headache, then you have to keep certain possibilities. Or by position, supposing he sits up and has headache, and lying down he becomes all right, then it's intracranial hypotension, and migraine should not be considered. If there is a sudden change in the frequency or the pattern of headache, a secondary cause should be kept in mind. A patient with migraine may develop a secondary pathology, and then the character or the frequency or both may change. Of course, if patients with neurological signs or focal signs or papilledema or seizures or altered sensorium, other possibilities or secondary causes should be considered. These are some of the examples. A 27 years old patient diagnosed to be migraine came, and she had arteriovenous fistula. This can present with headache. Brain tumor. People always, when they have headache, they are scared of brain tumor, and it's a common concern. But then headache without any other neurological symptoms is a rare thing, and it occurs only in 1%. So if you see 100 patients with headache and there's no other sign, then it's likely to be a brain tumor only in 1%. 99% it will not be a brain tumor. Then headache may be, brain tumor patients present with other symptoms. Headache is a presenting symptoms only in 5% of cases. Of course, as I mentioned, change in headache pattern, awakening from sleep, again, is a very, very characteristic thing of brain tumor. But you must remember that cluster headache can also occur at night and awaken the patient from sleep. Of course, if there is a fever, you think of abscess, and that possibility has to be kept in mind. These are two scans of third ventricular tumor. If there is a colloidal cyst, it leads to a characteristic headache because of the change in position. And this is another tumor on this side here is the third ventricular tumor. And these patients can present with headache and can be a problem. This patient I have taken from literature. This patient presented with status migrainous, responding only to sumatriptan, and was actually having a tumor, a third ventricular tumor, a brainstem going to brainstem. And the conclusion was that since the location of pathology was same, that of migraine, so the patient presented like migraine, but it's a very rare thing. Of course, an elderly person presenting with headache, we have to keep possibility of subdural hematoma, and 80% or 90% of patients with subdural hematoma will have headache, but then it will not be confused with migraine, or should always be differentiated. And if there is altered sensorium or fluctuating consciousness, one have to think of subdural hematoma. Idiopathic intracranial hypertension. Obese ladies, all of you must have seen that childbearing age, obese ladies who have recently put on weight, they present with tinnitus and visual obscurations, may have papilledema. And they are idiopathic intracranial hypertension. You do lumbar puncture, you have high CSF pressure. But remember that these patients have been diagnosed as tension headache, tension type headache in 80%, and migraine without aura in 20%. So this possibility always is intriguing, and one must keep this possibility. Rare causes of headache, which I will again refer to, like CADISIL. Patient has migraine-like illness. You do MRI, you see T2 hyperintensities, and there may be family has history positive, and you do a skin biopsy. You have osmophilic deposits. So these are rare things, but has to be kept in mind. And the patient has migraine. Similarly, mitochondrial disease, a 20-year-old female with mild mental retardation, has headache, vomiting, and a stroke-like illness, and you see ragged fibers in muscle biopsy. But they also present with migraine-like illness. So these are rare possibilities, should not be the first thing to be discussed, but should always be kept at the back of the mind. And if patient doesn't respond, one has to consider this in appropriate clinical setting. Now I come to certain common conditions like hypertension and headache. Quite often, a headache is attributed to hypertension. No, it's a rare cause of hypertension is a rare cause of headache, and in very rare situation, if patient got a severe rise in blood pressure or raised in blood pressure, then only it manifests with headache. Headache was associated with high blood pressure below 140 millimeters of mercury, 20%. 140 to 1659 millimeters of mercury, 23%. More than 160 millimeters of mercury, 24%. So there is no association in this study with the severity of blood pressure and occurrence of or frequency of headache. Similarly, 200 hypertensive diastolic blood pressure more than 120 millimeters, headache occurred in 40%, 44%. So, 56% did not have headache. So, headache is not a common, hypertension is not a common cause of headache and should not be attributed to it. Then, eye strain. Quite often, when a patient comes with headache or migraine, we get a refractory checkup done. The pain is usually frontal, and a patient usually is okay in the morning, and the eye strain or the headache appears in the evening. Hypermetropia, astigmatism, and presbyopia are associated with headache. Acute glaucoma should be kept in mind. And when you do the correction of the vision, then headache responds in 7 days' time. So that is the typical story of ocular headache. Sinusitis. Sinusitis is quite often overdiagnosed in patients with headache. Chronic sinusitis is not a valid cause of headache. And sinusitis diagnosed by physicians or patients turned out to be migraine in 88% patients. Acute sinusitis is associated with purulent sinus discharges, clinical or endoscopic or CT or MRI evidences of sinusitis, and headache occurs on exacerbation of rhinosinusitis. And there is tenderness on the sinuses, ethmoidal sinus or frontal sinus. You can elicit tenderness. And it responds in 7 days if the headache responds if the sinusitis treatment is correctly given. Cervicogenic headache. Quite often, patients with spots spine in the cervical region or atlantoaxial region may present with headache. I recall a patient who presented to me with severe headache for 3 months duration, and I thought he is a case of migraine, occipital headache extending. I gave him some analgesics. Then patient came on follow-up, and he told me, he almost scolded me. He said, "Doctor, I have a lot of faith in you. I'm coming to you again and again, and you're just writing analgesics to me." And then I got a MRI done, and then I discovered that he was having atlantoaxial tuberculosis. So this should always be kept in mind. Not every case should be MRI'd or imaged, but in certain cases, this is a common cause and can be confused. Similarly, Arnold-Chiari malformation. Patient on Valsalva maneuver will have a headache, and the tonsil is herniating down, and this can lead to raised pressure. So this also is a rare cause, but should be kept in mind. Now I go to next step, and that is the inappropriate drug choice. I mean, that may make our treatment, ineffective or cause to be rise. Now, when to treat acute attack? When the good and bad days are clearly defined, patient is really bad on a few days and is not so bad, then you think it may be migraine. Treat early and treat effectively. Well, avoid medication overuse, and simple medications like aspirin, ibuprofen, and naproxen may be used. You may use triptans, and in refractory cases, we can use opiates, acute management, not for chronic, and we can use non-pharmacological treatment, which I will again discuss. Management principles of headache are shown in this slide. We have to make a correct and timely diagnosis. We have to be clear that the patient is suffering from migraine or a secondary headache, or there is some dual pathology. Explanation and reassurance is extremely important, and we have to identify and manage the triggers, which I'll again discuss. And then proper intervention, which may be both pharmacological or non-pharmacological. Now, when a patient comes with acute state, we have to give treatment in the acute state, and you have to give aspirin or paracetamol or non-steroidal anti-inflammatory or triptans. So these are the first line drugs. Secondly, we have to, if the patient is not responding, then ergots and opioids may be used, and in difficult cases, you may use steroids and even oxygen inhalation. Now, begin with the cheapest and the safest drug with which one is familiar. Try for 3 attacks before discarding a drug, because no drug is 100%. So we give a drug and patient does not respond. We must give him some chance. Take the patient in confidence. What we are doing, patients will also cooperate. And then if he does not respond to 2 or 3 times, then only the drug should be changed. Aborted treatment, we should avoid acute treatment using too many rescue medications, because that lead to medication overuse headache. And simple oral analgesics like aspirin, paracetamol, codeine, ergotamine. Codeine, ergotamine should be avoided because they lead to addiction and medication overuse headache. For acute treatment in emergency, analgesics with or without antiemetic can be used. Diclofenac 100 milligram with Romestol 30 milligram, or triptans can be used. Any triptan which you are comfortable, sumatriptan, rizatriptan, or zolmitriptan, and now CGRP antagonists are also available. Zolmitriptan has been used, and we have been using nasal sprays with good response, and it is probably as effective or probably a shade better than other triptans that we have used. The CGRP antagonists have been reported, and they are as effective or sometimes a little more effective than zolmitriptan, according to the last study, which is quoted in the lower part of this slide. Recently, CGRP receptor monoclonal antibodies have become available, Eronimab, and then they are reported in episodic and chronic migraine in difficult to treat migraines. Very expensive. I have used in a couple of patients, but then when you are left with no other resort, and allergy and constipation and hypertension are the side effects, we have to gain more experience. It is newly launched, so I don't have much experience, but then this is a new thing. Then if there is a failure of treatment, then we have to review the diagnosis, review the compliance. Is the patient taking the drugs regularly? Review the manner and use of the drug, and exclusion of medication overuse headache. Now, this slide is an interesting slide, which I want you your attention, that this slide is showing the pathophysiology of migraine. This is the blow up of vessels and the dura, where you have neurotransmitters like 5-HT, CGRP, and leukotrienes and prostaglandins. Now, these neurotransmitters spread and take the impulse to the trigeminal ganglion, then trigeminal cordalis nucleus in the brains, in the cervical spine, and then go to the brain stem, to superior salivary nucleus, and then to the thalamus, and then to the cerebral cortex. And this is the circuit of migraine. Now, next slide shows to you that there is a vascular theory, and there is a cortical spreading depression. In the when there is a patient is having migraine, then there are hyperexcitability of the cortex, and there are triggers like light, sound, smell, fasting, and other triggers which I will again mention. Now these triggers facilitate the entry of pain to the central nervous system through 5H2 receptors in the trigeminal ganglion. And therefore, if we are able to block these triggers, then the pain management may become simpler. We looked at the triggers in our study, and this is one of my students did this study, and we found sleep, travel, and menstruation, and weather changes were the important triggers in Indian subjects. A larger study revealed that the triggers are mentioned here, which are shown as weather changes, fasting, dry air, or cold weather, physical stress, fever, traveling, and so on. So these are the triggers. And we have to identify these triggers. Patient should be asked about them, and we should manage these triggers. If we are able to do that, probably the management of patient will become better. So patient should have regular meal. Look after hydration. Many times patient don't drink enough water. They are dehydrated, and their headache frequency goes up. Taking adequate rest, stress reduction is again important. And then comorbidities like anxiety, depression, obstructive sleep apnea, fibromyalgia, and metabolic stresses should be managed. And medication and caffeine overusage to be avoided. Now, choosing the drugs for prophylaxis. Again, prophylactic drugs offer partial relief. They are not 100% in most patients. And the efficacy increases with time. So today we are giving, over a period of time, the efficacy will increase. Single dose may not help. Migraine is an erratic disease, so it is very difficult to predict the response of a drug, and one has to try it and then see. And sometimes patients undergo spontaneous remission. In migraine, there is a placebo effect. The physician matters how nicely, how clearly he listens, he advises, he reassures, and is again a variable. And I will again highlight this point of placebo response in migraine, which is up to 40 to 70%. In more complicated treatment, you will see higher placebo response, which I will again discuss. Headache diary we must maintain so as to give a objective documentation of the frequency and severity of headache and response to treatment. We have to stress the compliance and adherence to the treatment. Start low dose and go with higher dose, because if the patient has a lot of side effects, then the treatment failure may occur, and therefore one has to start low and go slow. Switch treatment after adequate trial, or if the side effects appear. Don't change the drugs very rapidly. Watch for interactions, some with abortive or between abortive and preventive treatment. Decrease the use of abortive treatment, because if we use a lot of abortive treatment or rescue medication, the efficacy of prophylactic drug will go down. Now, this is the now we come to the preventive treatment. Which are the patients who should be subjected to preventive therapy? And they are, if there are more than 2 or 4 attacks per month, then some people say 4, but some people, if the attacks are very severe, prolonged, or distressing, and interfere with daily life, one can even go to 2 attacks per month, and one can give prophylaxis. But you can decide for patient. These are only general rules. If there are infrequent attacks, but there is severe disability, there is aura, or there is hemiplegia or other complications, one would like to avoid them, and in that case prophylactic treatment has to be started, even if the frequency is not very high. Or if there is failed abortive treatment, if the acute attacks are not responding very well, then one has to go to prophylactic treatment also. Well, the strategies for preventive treatment are, sometimes we have to give short term preventive treatment. For example, premenstrual period, patient has got headache, so one can treat it for a short while, and then don't give a prolonged treatment. Or sometimes we have to give long term daily prophylaxis, or in certain other conditions. Now, choosing drugs for prophylaxis, again, as I said, it is not possible to predict the response of a particular drug. So one has to try it and then decide. Prefer monotherapy, but a combination therapy can be given, and which have a synergistic combination like tricyclic antidepressant with the beta blocker is a good combination. They act synergistically. Overuse of analgesics like ergot and triptans reduce the efficacy of prophylactic drugs and should be avoided. And decide on the basis of comorbidity or toxicity. If the patient got a particular disease, we have to decide which drug we are going to use for prophylaxis. The choice of migraine preventive treatment: antidepressants, anti-epileptic drugs. Antidepressant, we use amitriptyline, SSRI, or MAO inhibitors. Anti-epileptic drugs, valproate and topiramate and gabapentin. Beta blockers, propranolol or metoprolol, atenolol. And calcium channel blockers, verapamil and flunarizine, and ACE inhibitors and ARBs have been used. Other drugs like magnesium, riboflavin, etc., have been used by some, but not by others. And duration of treatment has to be 2 to 3 months, and I will again discuss it. And we have to optimize the dosage. The first line drug, according to some authors, is amitriptyline, propranolol, or nebilol. Second line drugs are topiramate, gabapentin, venlafaxine, and so on, which are mentioned. And then he thinks that flunarizine, epizotifen, and valproate are the third line. But we probably prefer valproate and flunarizine much earlier or much before than other drugs. These are certain emerging drugs which are like topiramate, gabapentin, lamotrigine, botulinum toxin, ACE inhibitors, olanzapine, tizanidine, venlafaxine, and CoQ10, and their efficacy. The dark ones, the dark columns are the efficacy, and these are the control. And you can see that all of them, these are effective according in different trials. This is a slide, interesting slide, in which, this slide shows to you the name of the drugs, anti-migraine prophylactic drugs, the number of trials at this time when we studied, the number of trials are published. Then what was the preference of the neurologists? So this is mentioned in this column. What were the preference of the general physicians, and what were the scientific rigor of these studies is mentioned here. The cost of the treatment is mentioned here. So you can see that propranolol was favored by both neurologists and physicians, atenolol mainly by physicians, and valproate more by neurologists. Obviously they use more of valproate, and so on. So this slide gives you some idea about the preference by neurologists versus physicians and cost of the treatment. Interesting is to note that certain drugs which have got higher efficacy, and certain drugs have higher toxicity, and their efficacy is less. So tricyclic, beta blocker, valproate, and flunarizine. So these are more efficacy, and they are less toxic. You can see here. Whereas lithium or SSRI or gabapentin, etc., their efficacy is much lower and their toxicity is higher. So this is a very interesting general presentation about the efficacy and toxicity. This slide shows to you that this is American neurology, this is Canadian, and this is EFNS guideline. And there's a reasonable concurrence between these three important academic agencies regarding valproate, metoprolol, flunarizine, propranolol, and topiramate. They all think that they have got class 1 evidence, and CoQ10 has class C, and they're much lower efficacy, and there's concurrence in different academic bodies. Coming to the comorbidities, a patient with migraine may have psychiatric abnormalities like depression, panic disorder, drug addiction, suicide, anxiety, so on. Or you may have neurological disorders like epilepsy, stroke, sleep apnea, and other disorders. Whereas medical disorders like peptic ulcer, hypertension, irritable bowel syndrome, and asthma. So we have to consider all these conditions and decide the treatment in keeping these comorbidities. For example, if a patient got we can use beta blocker if patient got hypertension, anxiety, or panic attack. Valproate if patient got seizures or bipolar disorders. Amitriptyline if patient got tension headache, depression, or cervical pain. This slide, lower portion, shows the side effects and what we have to keep in mind. That amitriptyline will result in weight gain, sedation, dry mouth, urinary retention, and sex dysfunction. Beta blockers lead to fatigue, sexual dysfunction, depression, and low exercise tolerance. Valproate, of course, you all know that it leads to sedation, weight gain, tremors, and liver dysfunction. Magnesium can lead to diarrhea, and NSAIDs can lead to GI ulcer and bleeding. So, if patients got arrhythmia, don't use tricyclic. If got asthma, no beta blocker. Sorry. If heart failure, no calcium channel blocker. Coronary artery disease, avoid methotrexate. We don't use it here. Depression, we have to avoid beta blocker. Epilepsy, no tricyclic antidepressants are epileptogenic. If got GI problems, NSAIDs to be avoided. And hypertension, hypotension or bradycardia, beta blocker to be avoided. In pregnancy, of course, a problem comes that which drug to use. Quite often, during pregnancy, in 1/3 cases, the migraine frequency goes down. And there's no serious effect of migraine on pregnancy, but in certain cases, we prefer to use paracetamol or simple NSAIDs may be used, sumatriptan to be avoid. Ergot and valproate, etc., are to be avoided. Try not to use prophylactic drug, but in difficult cases, we can use beta blocker and tricyclic antidepressants. But generally, one can do acute treatment and give rescue medications, and after pregnancy is over, then one can resume the prophylaxis. You have to take a case-by-case decision. Botulinum toxin has been used by certain headache specialists. We don't use them because of the cost. And PREEMPT trial has shown 347 patients versus 358 patients. It improved the headache related disability at 2 and 4 weeks. And their adverse effects were not much and was preferred by many people. And there are 31 sites, 5 units each you have to inject. And this I've tried to show in this slide. And there was definitely improvement at 24 weeks. But then, the amount used was about, about up to 200 units. So therefore, one has to be in this PREEMPT 2, 155 to 195 unit of Botox was required. So this is a high dose, and the cost is again a problem. How long migraine prophylaxis should be done? 4 months, 6 months, 1 year? So one was not very clear. Some people, the books write like this: on topiramate at 1 year, 60%, 50% could be withdrawn. So it means you have to continue for 1 year, according to some studies. So one of my colleagues, Dr. Bhui, who is now heading Bhubaneswar AIIMS, he did this study. And is 6 months of migraine prophylaxis adequate? I mean, that was the question. And then we found that you have to give longer treatment. And if the patient responds at 3 months, then you may withdraw the treatment. But then, here we took 127 patients, no improvement in 17, improvement in 110. So these were the patients who were followed up. And after follow-up at 6 months and 9 months and changing their treatment, it was concluded that 64% patients needed continuous prophylaxis medication for 1 year to sustain 70% improvement. 1/3 patients may deteriorate after initial improvement, and therefore they have to be given longer treatment. The most important predictor of persistent remission was 3 months. So if your patient responds in 3 months' time, one may decide to withdraw, but if it recurs, you have to give longer prophylaxis. RTMS in migraine has been suggested. Low rate RTMS at 1 Hz, high rate RTMS more than 10 Hz. And in Europe, there was a single acute migraine treatment with RTMS has been reported. And these are randomized controlled trials. In these number of patients, they were initially a small number, but except for this study of 201 patients, and they showed it is efficacious. And therefore, for acute treatment, this type of stimulator was provided, and the patient could stimulate himself and get improvement. We did a randomized controlled trial of high rate RTMS in migraine, acute episodic migraine, and we could follow after randomization of 50 patients in each arm, 3 patients, 12 and 13 patients withdrawn. We provided class 1 evidence of efficacy of RTMS in migraine, acute migraine. And these are the results. RTMS and placebo group both improved, but then there were much more significant improvement in the RTMS group. And these are, the improvement shown in RTMS, various headache parameters like severity, frequency, and drug intake, etc. They're all showing improvement. Another question is amitriptyline versus divalproate. Which one is better? We again did a trial on this, and we found valproate extended release was more efficacious than amitriptyline at 3 months, but at 6 months there was no significant difference. This is another trial which I don't want to bother you, but then suffice to say that in acute stage valproate was more effective than amitriptyline, but at 6 months there was no significant difference. Now, lastly, excluding the most rare cause. And, this is most important. For example, there was a very interesting paper in JAMA, which was that stop hunting for zebras in Texas. Yeah, and they said that if the physicians start searching for the rarest cause, it becomes very very stressful economically and psychologically and academically. And for example, they gave an example of intracranial, somebody was hit by a cricket bat, then you rule out a CT scan, and then you do a CT angiography to see if there is aneurysmal bleed or not, and then you do CT thorax if there is a chest pathology, and then there's a trauma, then you do further investigation. This leads to unnecessary investigations. When a patient with headache comes, well, we have to do blood counts, hematology, chemistry, lactate, imaging, MRV, angiography, lumbar puncture, ENT, orthopedic, psychiatric consultation. All these tests in all the patients are not indicated. Many patients we can rationally diagnose and treat, and if there is no improvement or there's indication, then we can do other investigations. There is a phenomenon of rule out medicine. The transformation has been to rule out, and this leads to high cost of healthcare. If we, many patients on insurance or something, so doctors don't feel bad. They want to order many investigations, many treatments, which may not be absolutely essential because patient is not paying. So that leads to unnecessary expenditure and problem. Then there is something like a defensive medicine. You don't want to miss a rare diagnosis, so you do all the possible tests, and in the process, everybody, patient suffers, and still you are not able to clear the rarest diagnosis. So this is again a problem. Many doctors have chosen to be wrong rather than really wrong and diagnose false positive. You do too many investigations, and then we are ending with something unusual, something not normal but still not abnormal, and then this leads to uncertainty, and therefore we have to take a decision how far to go and when to go. I'm not against investigations, but I'm saying is that they should not be done unnecessarily. They should be based on response, your clinical suspicion, and the result of other investigation. The rule out medicine is again a problem. When we have students, appearing for exams, then, what are we looking for? Are we looking for targeted assessment, and a person gives you few diagnoses, most probable diagnosis, and has a plan of investigation? Or there may be another student who has read quite a lot, and he gives a very long differential diagnosis and gives all rare causes, and then the latter would be rewarded and the former would not be. So I think the people who are examining, they have to understand that if you encourage them to be precise, to be accurate, to be cost effective, and reward that, then this approach will definitely be more popular. Conquering the uncertainty is impossible. There is sometime we in clinical medicine, we are not able to 100% make a diagnosis even at autopsy. So that uncertainty cannot be conquered always, and that thing should be kept in mind. I think we have to be safe, we have to be correct as far as possible, but sometimes we can follow up rather than trying to hinge the diagnosis. If it is not very important, of course it is important, you go ahead. Then, for example, a chest X-ray for pneumonia. Then you think of lung mass. Then you do CT scan. Then you go to aortic dissection. Then do CT angio, and then do MRI. So these type of investigations can sometimes be more confusing. And who pays for the uncertainty? Obviously, in India, 80% of patients have to pay from their pocket. Only 20% is supported by the government. So we have to think these possibilities. Self-medication and over-the-counter medication is a problem in our country, and that has to be considered. And consumer education is very important. I could get only one paper in literature talking about the cost-effective analysis of intervention for migraine in low and middle-income countries. It included this study was 26 interventional strategies over 10 years were evaluated in Russia, India, China, and Zambia. And what was interesting is that aspirin was the most cost-effective medicine, and it resulted in expenditure of healthy life years less than $100. But if you want one more day of healthy life year, you have to spend more than $10,000. So one has to understand, one has to educate himself, educate the patient, educate the colleagues, so that we become targeted, we become more correct, and we become more affordable also. Because if we are very unaffordable, then it is as good or as bad as being not there. So to conclude, I'd like to say that acute treatment of migraine starts with simple drugs and management of the triggers. Prophylaxis of migraine should attend to the triggers and their management or elimination. Select the patients for prophylaxis properly, and use these simple and common drugs like beta blockers, tricyclic, valproate are most cost effective. Consider efficacy and toxicity and comorbidities for long-term treatment. 3-month response is a predictor of remission. RTMS and other non-pharmacological treatment also have a role and should be appropriately utilized. Lastly, I would like to end with a controversial subject. We have all been taught that migraine was diagnosed by Galen, who lived at this era. But then I came across a shlok in Charak Samhita 2,500 years back, and that it raised that Ardha Bhedako va Syat Sarva va Ruchite Shira. The migraine their headache can be half the head or the whole head. Ardha Bhedako, half the head, va Sat Sarva, or it may be holocranial. Pratish Shan Ras Vikarna Roga, that is, it may be nose, ear, diseases, and face. Those disorders can also result in headache. So they talk of primary headache, which may be hemicranial or holocranial. They talk of secondary headaches, and this was done 2,500 years back. So I think, just to my friends, just to tell you that although we have been taught father of migraine or history of migraine starts from Galen, but no, probably it starts much earlier. Thank you very much. Stop share. Okay.
Thank you, sir.
Thank you. Yeah.
So now, sir, thanks for your presentation. We will move on to the question answer session. Just give me a moment.
Sure.
So the first question is, if there is a patient diagnosed with autoimmune disease and on immunosuppression, and if he develops a vasculitis related headache, what will be your line of action?
Well, if there's a vasculitis, is a more, are you talking? Yeah, probably systemic vasculitis, I think much serious condition, and that will gain priority over migraine. So I think, he will require immunosuppression with steroid and other immunosuppression depending on the requirement. And that's what I think, because migraine may be a problem, but a systemic vasculitis is a bigger problem and would take precedence over the management of migraine. Of course, you can use the migraine treatment if they are not contraindicated, but we have to use immunosuppression there.
Yeah. Thank you, sir. The next question is, if there is a obese migraine patient and the patient is not tolerating topiramate, what will be a choice as a prophylactic?
You see, um, yeah, obese patient, you try topiramate. Topiramate is quite often not well tolerated. So one can, I think, I give more emphasis to discuss the patient, look at the triggers, look at the comorbidities, look at whether he's got sleep apnea, and if that is required, that would require a separate management, and look at his blood pressure, look at other conditions, comorbidities. So look at the triggers, look at the comorbidities, and then decide which will be the appropriate. We cannot say every time reducing weight is a problem, but maybe I would first look at a obese patient. I would check at sleep apnea, and management of sleep apnea will solve many problems. The blood pressure may certainly be controllable, and and then one can decide. The list of drugs which I have given you, beta blockers, you can try. You may, all of them will add to a little weight problem, but it's all right. I mean, that's not so big a problem. We have to find out underlying cause and encourage weight reduction, doing some light exercise, trying to dietary management, and so on, rather than restricting only to drugs. We have to manage the patient overall rather than, yeah.
Yeah, thank you, sir. The next question is, what is the incidence of recurrence after you stop migraine prophylaxis in your clinical practice?
Absolutely. Very good question. We also thought, that how long should we treat? Generally 3 to 6 months. But as I showed you that, 60% of patients, 70, patients, that is 60% of them had recurrence. And therefore, we are not very, if the patient can tolerate, and then we continue for longer period. And, some patients certainly, you give them treatment, they respond nicely, and they are no problem within 3 months. I will give it a try. Can you stop it? If you can stop it, and patient got very infrequent attacks, then you can do with abortive treatment. But if he doesn't allow it, then probably go on to 1 year, 6 months, 1 year, or even longer.
Yeah, thank you. The next question is, how common do you find associated or comorbid depression in your migraine patients?
Uh, Very common. I can't give you any off the cuff statistics, but depression. But usually our patients in neurology have mild depression. They are not severe depression, like going to suicide, or very severe depression. So mild depression we are able to deal using amitriptyline. We start with small dose, go on to 25, 37.5, rarely going to 50 milligram, but most of the patients respond to smaller dose, and we are able to manage. But yeah, I will agree with you, about 30 to 40% of patients may have mild depression. Severe depressions in my practice I don't see, and maybe they may be going to psychiatrist or other setup. Yeah.
Yeah, thank you, sir. Just an extension of this question, with the use of amitriptyline in migraine, how to manage the weight gain issue? Do you see the weight gain in your practice? And if yes, how to manage?
Yeah, very good question. You use heavy dose of. You see, to be honest, I use very small dose. I start with 10 milligram, go on to 20 milligram, go on to 25, and most of the patients respond to that. If they don't respond to small dose, then rarely I have to go to very higher dose, and then I will combine with something else. Weight gain will be a problem if we use higher dose, and topiramate is certainly a good idea to use, But again, it is a tricky because the patient develops a paresthesia and they don't tolerate it very well if you go on to so using two drugs, smaller dosage may be a good idea. I encourage them to do some light exercise, try to reduce the triggers, and probably try to see if they can manage. Weight gain is a problem provided you use higher dose.
Yeah, thank you. The next question is uh, the cost of CGRP inhibitors or antagonist is very high.
Yeah.
So, what is your take on that? Is it possible to use these drugs in a condition like migraine?
Yeah, you are asked a very nice question. The drug is costing you. I'm not sure it's 20,000 or 70,000. I'm not very sure, but I had a patient who came to me and wanted this drug to be written, and I wrote it. And the patient asked for 140 milligram. I was trying to write 70 milligram. So I think the cost is very high. I think I don't know. It may be refractory cases, very refractory cases, paid by somebody and who wants to have it. That's a different thing. But in general, the for most of our patients, the drug has to be cheaper. I'm sure the cost will come down as the volumes increase. But from thousands of rupees coming down to affordable for a developing country, India like situation will be very, very rare. And I only wish it is more easily available so that we can have experience. You see, the trouble is if you use it only a few patients, you have no first-hand experience. Reading from trials is different. But when you have used and seen the patient, how well it responds. So at the moment, I'm on your side, worried by the high cost. But then let us see many drugs, which we are using it. I recall gentamicin when I was a resident. It was again a very, very expensive drug, and ceftriaxone. All of them have seen high cost, and in a couple of years they all come down and they become more affordable. But then, well, this is what the journey of every drug is. New drugs cost more, older drugs cost less, and then we have to wait or use it when you can. I wait till it becomes affordable for my patients. I mean, in very rare cases, when he's not responding to anything and you are left with no option, then you can try. But before that, I'm sure most of our patients have responded to it without CGRP antagonists so far.
Thank you, sir. The next question is which triptan will you prefer?
You see, sumatriptan, zolmitriptan, and rizatriptan. To be honest, I use Zolmist nasal spray, and I find it quite okay. I have no comparative data of my own to offer you which one is better. Sumatriptan tablet, well, a problem. Getting injectable is again a problem. And Zolmitriptan nasal spray, I find quite okay. Rizatriptan, I have used. I've even done a trial on rizatriptan, but I think Zolmitriptan for me is quite okay. But you ought to, whatever we use, we get more used to it, and that is what it is at the moment.
Yeah. Thank you, sir. The next question is how do you differentiate between basilar migraine and vestibular migraine?
Yeah, the patient with the basilar migraine will present to you with with altered sensorium, giddiness, vertigo, altered sensorium, and things like that. Whereas the patient will only present of vestibular dysfunctions are very common in migraine. In fact, they are much more common than realized, and the patient only presents with giddiness and vertigo associated with headache. So that differentiation is this is how I will suggest.
Yeah, so the next question is what is the drug of choice for prophylaxis in pediatric migraine?
Periodic migraine, yeah, very good. The best thing is what I generally one can try is beta blockers and cyproheptadine. So to be honest, I have used beta blockers quite commonly in children, It is much more comfortable than in elderly people. Sometimes they develop bradycardia. Children, it is not such a problem. And second thing, cyproheptadine somehow helps, and that I use. But then you can try other things also. Other things are more complicated, so I prefer these two. And this is my take on it. Yeah.
Yeah. Thank you, sir. The next question is, how do you taper topiramate or valproate in migraine prophylaxis?
How you taper, patient tells you how to taper. Patient, yeah, to be honest, these drugs, I decide with the patient. If he is comfortable, fine, don't do anything. If he is complaining, obviously, if the patient is distressed, we have to topiramate. If the patient is on 50 milligram, I immediately bring to 25 or change it, change it completely to valproate. Is again not so much of a problem, except sometime I recall patient going into severe comatose condition because of hyperammonemia. There is an emergency and you stop it immediately. Otherwise, patient is putting on weight, losing hair, or becoming tremulous, you certainly have to stop it. I mean, the patient is tremulous, you can't allow it. So we change it. We change it pretty rapidly. The speed of change is not same as in not so much of a concern as it in epilepsy. There you are more worried because of the recurrence of seizure. Here the pain will come. You will take something else to balance it and manage with acute management. So maybe we can go faster in migraine than in epilepsy.
Yeah, thank you, sir. The next question is, does topiramate have any effect on mood?
Topiramate, topiramate is more problem which I have encountered and which is reported also is mainly paresthesia and the stone formation. These are the major concern. Mood, migraine patients are anyway moody. I mean, they may not be. Migraine patients are quite distinct people regarding their intelligence and mood, and so that's okay. Maybe there may be individual cases, instances where you felt that, but for me, main problems are paresthesia, numbness, and then sometimes weight problems, and sometimes the stone problems. So we don't give it very long, of course.
The next question is, how does Botox help in migraine?
Yeah, I didn't show you that slide that it reduces the release of certain neurotransmitters and substance P and all those things. But to be honest, I have not used Botox for the cost constraints. I mean, 200 units. You imagine 100 units of Botox. I mean, if you're 20,000 rupees, it will be as good or as bad as CGRP. So, I'm not a great fan of Botox. So I inject Botox for various other considerations. Spasticity movement disorders. I'm very fond of it. But migraine, to be honest, I have not used it because of the cost. So I've injected in probably two patients. One was having trigeminal neuralgia with something, and there with the headache, and there we used it. And no, blepharospasm with this thing, migraine. Not many cases. No.
Thank you, sir. The next question is, what is the role of gabapentin in migraine prophylaxis? Any experience? Or
To be honest, it is written in literature. It has been used, but to be honest, I think gabapentin is that drug for which they are trying to find an indication. So they started the anti-epileptic drug, then they went to neuropathic pain. Now they are trying migraine, and therefore I'm still not convinced that gabapentin we use in neuropathic pain, but for migraine I'm not a great. I don't have great personal experience, and I think these are just to find yet another indication for a drug which has not done very well. So that's my condition.
thank you, sir. The next question is it safe to use tricyclic antidepressants in first trimester of pregnancy?
No, I told you, if the patient comes with migraine, first time, in 30, in 20, when one third cases, the frequency of migraine will go down. If headache is a problem, I will go on to use aspirin or give abortive treatment. Avoid and tell the patient that these are the problems, you can do. But if the patient is really, concerned, then, but I would avoid, it has been written that you can give it in later on, but I would not give it. Why to give, it's not such a big problem. You can give oxygen, you can give aspirin, and you can give paracetamol, and see, can you do away, can you give beta blockers? Maybe I would not try to give anything and hope that my patient does well. I mean, that's what I do.
This question, sir, you partly touched, but if you can elaborate more, what is the role of lifestyle modifications and exercise in migraine?
You see, that's a tricky question. On one hand, you have exercise and you exertion and all those things, and those type of headaches which get precipitated by a little exercise. But I think exercise also has an antidepressant effect. It's a great endorphin generator. By the way, I'm just very happy to tell you that I have done my trial on myasthenia gravis, walking 30-minute walk has just come out in European Neurology. I mean, proof has gone. So
Uh,
so I'm a very, very happy person telling exercise and walking. And, that has a great effect on endorphin release. And endorphins, I have not brought out those data. In migraine, we have done RTMS and endorphin release and all those things to make it very complicated. But then there is a marked increase in endorphin level after exercise. And same is true with RTMS. So you may not give RTMS, you may give him exercise and light exercise, and the patient will be happy, and he will be as if he's got a morphine injection or he's got RTMS because endorphin is released. So I very much believe in lifestyle modification, regular diet. Dehydration again is a very big problem. India people have to drink a lot of water, and many people don't drink water, and they are subclinically dehydrated. And there are studies that if they are properly hydrated, their headache frequency goes down. If they are dehydrated, headache increases. So I think I insist on water intake. I mean, that I have learned very recently, because, writing a chapter in our book on nutrition, when I read about hydration, I realized, oh my, so many people don't drink water because it's not clean, not nice, and so on. So they are dehydrated. So I think hydration, managing euglycemia, avoiding stresses, doing light exercise, and trying to put on some control on weight, avoiding alcohol, avoiding too much of coffee, etc., is all very welcome and should be tried, and will reduce your drug requirement also.
Yeah, thank you, sir. The next question is, can we combine TCA with valproate?
TCA with one is anti-epileptic, other is epileptogenic. So if you want to try, I mean, actually, TCA we combine with beta blockers, and they have a synergistic action. So I have valproate is a very tricky drug. It has lot of side effects, even in children, adults, and ladies. Migraine is common in ladies, and you are scared of giving valproate to ladies. Any age they may have problems with it. So I would prefer TCA and use beta blocker rather than valproate. Yeah, I think so. Yeah.
Yeah, thank you, sir. This is the last question that we will be taking. So the question is, how do you clinically differentiate between migraine and tension type headache?
Oh my, this is the very difficult. Yeah, in the last, nice you asked this last question. You have to interview the patient. You have to talk to him, and if there is stress, many times these episodic migraine becomes with repeated attacks. They begin, there is sensitization, and they get allodynia, and there's a constricting feeling around the head, and they're associated with allodynia. So I think you have to talk to him, look at the background stresses, differentiate fibromyalgia, which may be also coexisting and has to be diagnosed, and then you have to make a differentiate. That is not very straightforward. The things are overlapping. A patient may have anxiety, he may have depression, he may have tension, fibromyalgia, and allodynia on top of it. The repeated attacks may lead to cephalic or non-cephalic allodynia. I didn't include all that in my thing. We have got some publication on these things also. But then if you sometimes it's not exclusive that patient has got this or that. Patient may be having a bit of everything, and we have to manage realizing that the 2 or 3 factors may be contributing accordingly.
Yeah, thank you, sir. So that was the last question. We still have a lot of questions pouring in, but in the interest of the time, we have already exceeded by around 10 minutes.
Yeah.
So we would like to end the program. So I would request Mr. Sutirtho to propose the vote of thanks.
Good evening, all. I, Sutirtho, on behalf of Johnson & Johnson, first of all, thank our eminent speaker, Dr. UK Mishra, sir, for giving his valuable time and this wonderful topic. And he has shared us throughout this 1 hour of session. I thank all the 700 delegates who have joined us online and attending this meeting. And they thank you for sparing out your 1 hour of valuable time. I thank Dr. Mukund, our medical advisor, who has faced a lot of challenges while designing this topic and guiding us throughout this session and having us successful conducting for this. I thank Mr. Praneeth Surana, our marketing head, and also all the sales leader for assuring that we have a good attendance. And lastly, I would like to thank our field colleagues who has put up their hard work and they have got this attendance. So wishing you all a very happy Holi and good night. Thank you.
Thanks a lot, sir. Thank you.
May I say just a word? I thank. I'm very thankful to the people who asked questions. Many of the questions were difficult, but then such a large number of questions only show that people have at least listened and ask questions, which is very, very nice, because if you don't ask question, the speaker gets demoralized. And I'm sure our host don't regret choosing this topic. Thank you very much, and wish you all a very happy Holi.
Sure. Thanks a lot, sir. Thanks.
It was a great learning experience for all the attendees. We have had a very good audience, and still there are around 10 questions unanswered. So that tells us that there was a lot of interest in this topic.